We have seen Atul, thank you very much, and of the organization of CHIP 2025 and CVT, give us the chance, and we are doing first time live relay in your meeting and Saturday. Welcome everyone. We are starting a little 10 minutes late, but you see all the staff. You know, we have full day Sunday. Sunday we have 34 elective cases tomorrow, but this is just for you. But we are happy to have it, and hopefully we'll go through a lot of educational points in our next 40-45 minutes. And you see we actually have 9 intervention fellows, and 2 of them are assisting today, Sophia Thang and Sabrina Kumar. And of course, in terms of our CBTs, all here, the Asif and Hakim, nurses, Will, Alina, and imaging is Kiski, which you'll hear. And of course, my main person on left side, Dr. Kini, which you all know. And we are ready to start, if okay. And I know the extreme, very experienced, intelligent faculty, which will help us navigate through this complex case. If that is okay, we are ready to start. Okay, so this is yours, CHIP India.
Yes.
You can see it, you can hear us well. And let's go to the slides. Nothing to disclose. This is a 76-year-old male, presented with dyspnea and chest pressure, has ischemia, and otherwise used to be okay. Didn't have any procedure before, good LV, various risk factor, but all controlled. LDL 45, CRP1, A1C actually now, today is 5.7, and LDL has even gone down to 39. Good creatinine, good medical therapy with a good control, because we all know now, and that lot of emphasis has been done in both ACC and European guidelines on the post-PCI treatment of these patients. It's very important that not just putting a stent alone is not enough, but subsequent treatment can decrease their further revascularization and further events. So basically, this patient had a cath about mid last month. With a 2-vessel disease of the RC and LAD. RC was taken care. Syntax score was 21 and EF 58. And now today, and we'll show you that, for OCT guided PCI of long calcified aneurysmal proximal and mid LAD using OA followed by DES optimization. I'm calling this as a O3 or O cube. And we show the case very quickly, but the appropriate point of view. Ischemia, double medical therapy is appropriate. Anu, you want to show the case first?
Yeah. So if you see, this is the
go to the fluoro.
LV gram, EDP, probably diastolic dysfunction. EDP was like 18, normal, EF, and this is the right coronary artery, the PCI that we did from last time.
Flush.
Left side, non-obstructive, large circumflex.
Flush.
And then here we have the LAD. So this is something, I know there's a combination of old way of understanding before imaging. Is there calcium or no? We used to do dry cine. So you can see, even on dry cine, there is a tram track calcium that you can see in the prox to mid LAD. And this is the angiogram. So after the first septal, there is disease, and then there is that ectasia. After that, you see a diagonal that is arising, that's totally occluded, likely from the level of that, from the ectasia, up to the second septal disease, and after that, on like 95% further down. Majority of the calcium is between the first and the second septal, which is involving that ectatic area.
So with that ectasia, Atul, we can take the opinion, and of course, Dr. Colombo, most experienced cardiologist of the world, is there, that would he use orbital atherectomy in this case? Because, you know, we always have been teaching that get away from tortuous vessels. This is aneurysmal, continue to play. Would you use orbital or just go with the rotational atherectomy? Continue to play that so people can see. Yeah.
Yeah, I'm... hi, Shamin.
Yeah.
Very nice case. It's a long, not severely diffuse disease. The lesion is relatively focal, but there is some additional diffuse disease. I would definitely consider rotablation. Personally, I prefer rotablations, standard rotablation, and so I will definitely do rotablation, and then do intravascular imaging, and then decide further.
Beautiful. All right. So clearly, as you said, that is what our usual teaching is. Now, can we deviate from the usual teaching and try to explore other part? And if you can go back to the slides. So we thought that maybe, as you know, that the only guideline so far has been in 2021
Tell him to show this
in the individual patient subgroups. Basically, that both rotablation and orbital are 2A, 2B. Class 1 still has not made to in the calcific lesions and so. Now, these are the two devices. They have different mechanism. One, of course, the differential cutting at the tip. Orbital, which is the orbital atherectomy, has a eccentric crown, which does cutting back and forth. And this is where the key is. Rotational atherectomy and orbital atherectomy, two differences, different mechanism of work in both of them. One goes forward only and does the ablation compared to orbital, which does the ablation both backward and forward. So I was the one who did the first case in December 22, in 21 in India of the orbital, and I know that orbital is being used in about 200 or 250 cases per month. Rota is still about 3 to 4 times higher because that's a comfort level. And this is where it works. Her techniques are a little different. As you can see there, one is the packing, go forward and come back. A lot of people go very high speed fast, which is we still do not teach that. But usually is the, and compared to the orbital, you continue to go forward motion. Anu, you want to say something?
If you go back to the previous slide, I think how rotational atherectomy was first made by David Oth based on all the physics principle is differential cutting. And that is something I think we need to understand why pecking motion is so important. So differential cutting works, which means it only ablates the hard surface, which is calcium. It has to done in a slow motion. So pecking motion is very important, and which we teach at every time how pecking motion has to be done, and that is what people have to learn. What is the pecking motion? Because that is how rotational atherectomy works. Differential cutting, and that it works on the hard surface only when you do pecking motion, not the motion that people are right now talking, keep going forward with a fast forward speed. That is not the way it works.
Yeah. And the second point is, which we all know, sometimes rota burr can stuck because there is no ablative surface proximally. Orbital does not get stuck because it's both forward and backward ablation and the eccentric crown. But before the year end, we will have the first in man. We have designed the rota now, which has ablative surface on entire crown, proximal and distal on the cone, and whether it will do better job or not on the animal day, on the ex vivo, I had done some work. Looks quite good. So let's go to the real case now quickly, just completing that this is orbital atherectomy technique, which is speed dependent. You do 80,000, give you 1.6 millimeter lumen. You go to 120, same bar, or they call it crown, gives you a bigger lumen up to 1.8. But we say 1.8 by definition is contraindicated because we use 1.8 in the past, 120K, and used to have perforation. Advancement is technique, slow 1 millimeter per second advancement, 20 to 25 second run, and even if you cross, you do multiple passes. Why? Because it's an eccentric crown. It will do ablation in various part of the segment. Technique, which one you prefer, we have published. I think overall can use either of them. Today is a little questionable. Angulated lesion, little tortuous with a, we'll but try very cautiously, and if need to be, we can stop just before the aneurysm. That's where we are. So, Anno, ready?
Yeah. So I think using this ablative techniques, which is especially rotational atherectomy, orbital atherectomy, understanding the device, understanding the technique is a key, and that is what we keep focusing on, how to do it right. Because one of the dreadful complication is perforation. So if you learn to do it right, you will safely do it in complex cases like this one or more cases that you see in your practice, and help more patients.
And this is shown very clearly. This is the advancer knob, same, you lock it back and forward, and this is the you see the brake pedal, which once you're doing it, you have to press it so the wire gets stuck, does not move. And then these are the two speeds, 80 and 120. And I actually say that, remember, there was a mini crown with a speed was 40 and 80. To me, this is a very effective device. I think should not go beyond 80, because that's where you get into trouble. But anyway, we are ready to start now and advancing. Now, there are two types of the orbital wire. Viper wire is available. One is a Viper wire Advance, which is the usual one, and then called Viper wire flex tip. Flex is the proximal portion is more flexible, it tapers down, and this kind of case, you'll use the flex tip. That's what we have used, the Viper wire flex. And I don't know whether Viper wire flex tip is available in India, because I know in India they don't even have a rotaxer support. Only rotafloppy is available. Now, first you check the speed.
We're done.
Done. Okay, we are ready to start.
No, we go.
Go. Back to same push and pull. All these are over the wire devices, both rota and orbital. And so just slowly see the wire and the guide catheter movement.
One thing, let me just say, so before that, how would we have wired this? So this is where it is. So you will go with your usual over the wire catheter, whatever it is. We use fine cross, and we took the fielder wire. So when you have an ectatic area, what's the concern? That usually your exit is not that easy. So at the ectatic area, fine to and fro motion, and we were able to get through. So this was the fielder and the fine cross. So this is the case. You cannot do primary wiring. Always use some other wiring and then exchange.
Dr. Samin, Dr.
Yeah.
Hazra here.
Yes.
You
Yes,
said
PK.
at the very beginning there is a
Yeah.
differential cutting.
Yeah.
Don't think it's a myth. If there is only differential cutting, there will be no dissection, no intramural hematoma ever in any angioplasty.
Very good point. Very
You
good
see-
point. Yeah, I'll tell you what happens. No, pull back a little bit. So key is that once it will cause differential cutting, but if your tissue cannot deflect back, like angulation, that's where you get a dissection perforation. So key is the phenomena of deflection of the elastic tissue does not apply all the time. You're right. When we say nice lumen with a rota and orbital, this is a theoretical. 70% true, other 30% not true, because if the vessel is angulated, so it will not differential cutting because it cannot reflect, it cannot deflect. It will still remain in the path of the vessel or path of the burr.
Yeah, Dr. Hazra, other question also is, remember when in our algorithm we always say moderate to severe calcium. So if imaging is used and people want to understand, if you have 90 one quadrant, 2 quadrant of calcium, we always say stay away from atherectomy. That is where I think many times you see that no matter what we say, how it behaves in the body is a different story. That is why when you are doing it, it may not deflect and cause some dissection. So it works the best when you have severe calcium, which is 3 quadrant or even 4 quadrant.
And all the new trials of, just want to complete the sentence also, that all the new trials of IVL require that you do imaging, your calcium arc has to be more than 180 degree. Good. So we are ready to start now. Yeah, sorry.
When is your imaging catheter is going to come out from your pocket?
Little later, after that, as Colombo said, do the ablation, then we do imaging.
Okay.
Yeah. Okay. So this is 1 millimeter per second forward. Now, it's a machine will make a beep at 25 seconds. So you have to have that control that how many seconds forward you are going, because you have to then pull back, because it's going to do ablation both times. So you think about you advance like 12, 15 seconds and then start pulling back after that, because 25 seconds you'll hear the beep. And that's what we are going to do now. Anu is going to do. Start pulling back. No, let the noise
The
come.
device speech will be your
25 seconds.
endpoint.
Because
Yeah.
you're,
We are still going through it, yeah. So it's still far away, but
I
same.
think we can
Always
stop
after
it
some time, your hemodynamics, you are seeing that blood pressure should not go down, because that's the precursor for slow flow. If it's down, we actually will, and our nurses will give neosynephrine, 100 microgram or 200 microgram bolus. Now see, it slowly has gone to that lesion.
okay, I think
What
I'll
is
stop
what
here.
will be your endpoints of effective calcium modification? Is it sound?
Very good point.
Passage.
No, in this one, just once you crossed it. Same. So both of them, key is that whether rota or orbital, that once you have gone through and the sound does not change, and then you do a few polish runs. But advantage with the orbital is that during even polish, you will do some ablation compared to rota unless you change the wire tip, make a rota in eccentric direction. It usually just does not give you any additional lumen, while multiple passage with the orbital will give you, just show one at 25-second noise.
Oh,
Yeah. So, okay.
why is it not making?
It
I'm
makes
stopping
25
before.
seconds. 25 seconds. Now, see that we've gone through. This is the 2 times. Now going to go again. And you are going to hear the noise this time. Keep going a little more. You have to go further. Yeah. You start pulling. Yeah, that's the noise. So that you have to coordinate. Yeah, now is too much a little bit, and then
Okay.
pull back the same. Good. Ready? You want to do one more?
No,
Okay.
Come
So
on.
now same, although there is a, the
lock it.
lock. Now we have to release the lock and lock your advancer knob and just pull it.
No, don't you do the thing?
Yeah. Yeah, that also, the glide assist.
Yeah. Yeah, now it's glide assist.
Yeah. So see this, which is
Okay,
basically,
advance the wire.
yeah,
Get the
it helps.
run through wire.
Yeah.
Can you show the ceiling camera? That is a glide
it.
assist, just like we do the dyna with the rota. Initially, it was not there. Later on, they upgraded it. Version 2 or 3, they have a glide assist.
Yeah,
Dr.
overall
King,
in the,
don't you
yeah,
think
sorry.
that Eclipse trial has killed the orbital in US because Ajay Kirtania is from your country.
Yeah.
Agree?
Yeah, I'll tell you the numbers latest. The latest numbers are that we have, let's take a picture now. So
Okay.
we are taking the picture, and I'll tell you on that issue.
No, in
So we're good.
Eclipse study also, there where they did the imaging, the results are better as compared to orbital atherectomy rather than NC balloon.
Yeah, no, but only one problem is, listen to that part. Absolutely correct statement that imaging gave you better MACE rate, but it still did not make significance. But what has happened is, even with the imaging, the complication, there were the 2 major complications occur in the trial. Slow flow and perforation did not change by imaging. So that's the one of the concern. Now, let me tell you what has killed the orbital or rotational, IVL. Right now, the latest data of the ACC NCDR, just like every PCI registry, every case is submitted to the National ACCA registry, and they keep giving you the up-to-date every quarter, your data compared to the national. The last quarter data which we got in the first quarter of this year, at present, there are, IVL is used in 9% of PCIs, rotational atherectomy is used in 2.1% of PCIs, and orbital in 0.7. So significant drop. 2 years ago, the orbital atherectomy was 2% and rotational atherectomy was 5%. So there, yes, I mean, has not been completely killed, is on resuscitation measures, maybe getting little epinephrine, little CPR. Yeah. Good.
Okay.
So wire has been go side by side. This is the now let's
Where
open.
is the yellow?
Yeah, let's go.
While you're doing that, Dr.
Yeah.
Sharma and Dr. Kinney, this is Prashant Kaul from Piedmont in Atlanta.
Beautiful. Yeah.
Nice case so far, and I just wanted to point out something you guys just did there, which is something that I do as well, which I think makes a lot of sense, is just rather than switching out the wires at this point, you've put a parallel wire,
Yeah.
and then I presume you're going to do your imaging and other things on that other wire in case you need to go back with orbital and so on. But
That is correct.
It
Yeah,
makes
yeah.
sense to
Yeah.
do a parallel wire there and quickly check on that wire.
So yeah, very good. 2 things will do. With this, the balloon going to do some additional, I would say, modified 1 wire scoring. And the second is, and the second is that if you need to go, only problem is with the orbital, I would not go with 120. Rota, if you need to, and you think you have not created a cracks, then you can go to a bigger bar. But orbital, I would say 120 we are away. Let's say if I did a last 100, the OA, probably 1 case, we did 120. But yes, very good point. So it's going to do two things. Basically try to look into the cutting balloon, as well as advantage for you to upsize your or change your modification strategy.
Okay, go.
Here.
You have
Yeah.
the OCT ready?
This is the 2.5 and we have the OCT ready. Yeah.
Dr. Sharma, while you
Yeah.
are doing your imaging, we are just going to come back to you in 5 minutes. We are over to Kirti Punamia, who's ready to show what he has at Escorts. Can we switch over to Escorts? Otis?
No.
No,
Listen,
but let's show the
let's
OCT.
finish-
Guys, we
finish
always
the
say,
OCT and
do
yeah.
not change this
Kirti,
back and forth always creates trouble because there is
Kirti,
no
audio?
single message goes
Hello?
through. Yeah.
Dr. Sharma, we are back with you.
Yeah, but you
Good.
remember what we always try to say, that by this interruption, you lose the audience what to do. We always say, you do one, even you want to do a 15-minute continuous transmission, one center, and that's the way it should be. I'm always telling, even ACC, TCT, we told everybody, do a time, you give 15 minutes is needed, 15 minutes fine, but should be continuous in one place. Anyway, let me just control here now. Let me show what we have done so far. We dilated after OCT was done, and they'll show the OCT run. Why don't you show the OCT run?
OCT essentially showed calcium like we had seen before that area, 360 degree calcium at that area.
Yep.
So 2.5 balloon actually expanded, but we went with a 3.5 cutter. So this was a 2.5 balloon, and then you see that just after the first septal vessel, this is a 3.5 cutter, 18 atmosphere and 48 stent now. The distal vessel is 2.5, we put a 48 stent, we put a high pressure 3.5 at 18 atmosphere at that area, and now we are ready to do the OCT. Let's do the OCT. Come.
Okay. All right. So ready for the post-procedure OCT. We are not post-dilated. The wire a little further. Post-dilated the mid-segment, but proximal segment has been post-dilated with the 3.5 at 16 atmosphere. Whether subsequent need to be done, we'll see. But this is it. This is it to show what we have done so far. Combination of okay. Live OCT, please.
Yeah, we can check the path.
Wait. He
Yeah.
has to tell us.
Mhm.
Okay, good. Okay, go.
1
Not
second.
not you.
Enabling, calculating. Yeah, cine inject.
Go.
Yeah, great image. You can take it out.
All right, Kiski, teach us what's going on. What do you see?
Sure, of course. This is both stent. We do angiocorrelation. This is the Abbott Ultron 2.0. We have a calcium detection and the AI integrated the lumen-like area measurement. So now it's calculating angiocorrelation. Confirm. Okay, this is a post stent. So I go through the distal. Now, yeah, it's the edge of the stent. Actually, there's like slight intimal dissection at distal edge. Now coming to more proximally, yeah, stent looks like circle shape, like well expanded. And I see a lot of dissection, but it's behind stent. So we cover the dissection by the stent. And proximal more expanded. Like this is the level of the ectatic part. Of course, we cannot oppose perfectly, but stent is well expanded. And now come more proximally. Yeah, our tightest 360 part expanded really well. The area is like 9.5. It's really expanded.
Come to the proximal edge.
Yeah, proximal edge also looks like no major dissection, but looks like slight intimal dissection. So far the distal edge and proximal edge looks like some slight dissection, but stent is well expanded. Of course, the point of the MSA is like not that high because of the small vessel. I can measure manually because sometimes it's not.
MSA is okay, and even the dissection based on, I know there was some discussion, based on the OCT criteria, it is still intimal, angle is very less, right? So not more than 60. We can leave alone the distal edge as well as the proximal. I think we are seeing it because we have the OCT. Angiographically, everything looks good.
Let's take a better picture with the angiogram now. I gave some visual dilator. Let's take one more good picture, then we decide what to do distally. Because I think the proximally everybody agrees, very nice lumen expansion, stent expansion. Okay.
Go.
And remember, this vessel has some disease downstream even before. Let's find out from Dr. Colombo and Dr. Atul and everybody else, all the experts,
Yeah. So,
that's what you do.
Antonio, what do you think in this the original disease? Would the drug-coated balloon would have been a good option?
In our experience, we have drug-coated balloons available for de novo. In this lesion, I would consider a short stent and a long drug-eluting balloon. We do this procedure with a pressure wire monitoring the distal DPD. So I think, but in United States, you cannot use the drug-coated balloon for de novo. So I think this is the standard approach that we have utilized for years.
There's that angle and all that.
Okay, but
Yep.
now we would use the drug-coated balloon in this situation.
Angiographically, the proximal LAD also catches your eye a little bit. I wonder if we could look at the imaging of that segment as well a little bit.
Good. Let's see the before the stent, Kiski.
Oh, sure.
Okay, that's on the wall there outside.
I come back to the initial IVUS.
Let's
and the
show
OCT.
what we see on the OCT proximally.
Yeah, so this is the initial IVUS. I mean, after the OA. So this is our like a tightest 360 cross sample. Just after the OA, the surface is shaved, but no like fractures. But after that, like a huge like dissection. This is just after the OA, like multiple dissection.
So then we should put a stent proximally also.
No.
No?
Hold on. Please,
second,
go
one
back,
second.
go back. Bring that thing there.
Yeah.
Now go back to the proximal edge. You showed us before. Go back to the proximal edge.
You mean post-stent?
Post-stent?
Sure.
Yeah, don't go what was before.
So this is a post-stent.
Yeah. So now let's go. Okay, it's only intima, right?
Yep.
And can you give us a measurement of the?
Maybe, anyway,
Yeah,
it's
it's
like
not.
like a 20, 30 degree. Of,
Yeah, it's only 20, 30 degree and not even 2 millimeter.
Yeah. Longitudinally very like
Yes.
focal. Or might be some
yes.
side lunge.
I would leave everything alone,
Yeah.
proximal as well as distal. What do you think, Kiski?
Yeah, it's not a major dissection at the proximal edge of the stent. So in the point of view dissection, we don't need to cover.
Yeah, point of
Julio,
dissection, we
what
don't
is
need
your
to
opinion
cover.
about the dissection in the OCT? What's your opinion on that?
Tell them to put it here.
More than the dissection, I wanted to move the proximal reference exactly at the point where you can see the EL, the proximal reference.
You want to go back to show the OCT? Go? Yeah.
Go back to the
Tell him to show
most
here.
proximal segment where you can see the EL. You can see here. That is what the people were alluding about the proximal segment. You can see that the lumen for the proximal ostial LED is 377. That is very small. So and that was the question that was addressed. I'm watching to the angio. I seen that the true proximal part is a little bit suboptimal. And then now we needed to deal with a good result inside, but the proximal part of the LED is with a small lumen. Normally
What's
we
the
try to achieve
CSA?
8,
back.
9.
Go back there.
And here we
Proximal
are
is how much?
377.
That is how
Yeah.
much?
Around
MSA?
here is some
Yeah.
block.
Yeah,
It's
but
true.
that is, we never
I think
planned
we
to
put a
go to that
3.5.
area. No, they're talking
15.
the proximal
Yeah.
LED, which we
Yeah.
never focused on.
Yeah, but now there is a lumen there. There is a disease.
Go back.
You can always leave it as it is and bring back in 2-3 months for stress echo. But almost no doubt at some point
Yeah.
there will be staged PCI to proximal LED.
Yeah. No, I
So
think
what's the
it looks
MSA
very
there?
important other
Proximal
side.
LED?
3.1.
Oh, 3.1.
Cross section
Yeah.
area is 3.1.
Okay, so it's two different criteria we are talking. One, as far as the dissection is concerned, I don't think we should do
Okay.
anything because this is the teaching point. Okay, putting a stent is very easy. What we need to teach is when not to do additional stenting. And I think based on imaging and angiography, there's no need for additional stenting.
No,
But now,
proximal lumen is tight.
no, that is different. We are talking proximal stent edge. Proximal stent edge is okay. Now we are talking the stented segment, the proximal LAD, you want to make it normal, then it's a different story. We are just talking the area of interest, the area that we intervened.
That was exactly the point we're making. I think the proximal and distal stent edges you could, let go, but the proximal LAD segment where there's de novo disease, that was the question, and your OCT image shows that now.
Okay.
Other option
we'll
is
do
you
a
can,
four
we
of
can bring patient in 2-3 months time for stress echo, and if necessary do angio, because that way you will assess your distal age, because distal age, that's another problem.
Actually, you can reclassify the proximal segment, prevent-like lesions or non-prevent-like lesion. If you have FFR, which is positive, it is a non-prevent-like lesion. If the FFR is negative, it is a prevent-like lesion. You can just leave it.
Yeah. But I think in this case, there is a reasonable, it's a quite narrow, if you look into it, angiographic. Let's say you don't have imaging, you don't have anything. I would say if this patient comes here with angina, you probably will put a stent proximally. So I think nothing wrong in just putting a 3.518, another Zions stent, but that's a minor thing. But I think we had a very good discussion. We don't need to do anything for the dissection, but there is a lumen is decreased proximally. And every view shows eccentric 70% lesion angiographic, confirmed by the smaller lumen on the OCT. And we just put one extra stent. And if that is okay, Atul, I think we can conclude our presentation from here. And you go to Kirti on your completion of your other case. But we went through various points doing orbital atherectomy, optimization with the OCT, so that O cube concept has been implemented in today's case.
So would you consider doing an FFR before you leave the case?
No, I would say that I would put a stent. You ask other faculty, tell us what they say.
If you decide to put a stent, will you nail the ostium or you do a crossover to left main?
No, nail the ostium. Definitely, we don't want to make further issues there. I would, and I think there is enough room. There is enough room there, yeah.
So, Dr. Sharma, in support of the fact that you can potentially leave it, is this plaque is fibrotic and fibrofatty. It's not purely lipid. So you don't have, I'm talking about the proximal part.
Yes.
And so you don't have a very high risk profile to get destabilize this plaque. So this is something that could be taken also into account.
All right, so Atul, take the vote of your panelists, yes or no, and then we just conclude it to follow what we need to do.
All right, so let's take a raise of hands. Who would say treat the LED proximal lesion now?
How old is she? How old is she?
There are 1, 2, 3, 4, 5 hands.
And how many total people?
Now.
What else I would definitely do in my case when I did it in Australia, I would definitely do DCB, blended therapy to the mid vessel, because this is long and now about to put a second stent. Long stents at outflow is not good. It's limited outflow. So in US you cannot do that, but in Australia I just put DCB, 30 or 40 millimeter DCB there for 3-4 minutes.
I think both distal as well as proximal needs a stent. Distally small and proximally around 18 millimeters.
I think we are getting.
I think that is too aggressive.
Please.
I think we just consent.
I think we can.
So many people with different minds.
Yes, but that's okay. That tells you that more than one right way to do. I would only say, Atul, and I know a lot of people wanted physiology. We know that this case has a positive IFR and FFR now because of do you see the LAD disease? And this is what we learned from various trials, that do we need to eliminate entire IFR, FFR and normalize versus you do what we usually do. Particularly in this particular case, is LAD diffusely diseased, distally or moderately diseased, FFR, IFR both will be positive. So I think the way you said 5 yes, and how many were no then? How many in your panel and moderation? Total people.
Sanjeev here. Okay, Sanjeev Sharma is taking the poll and he's making a comment now.
Yes.
Majority of panelists are opining for FFR before finishing this procedure. So let's do an FFR and have a clarity about the significant ischemia.
Yeah. So final call we'll leave to the operator. Yeah. He's the best person who's taking a decision. But we've had a great discussion, and this lovely case, and it deserves a big hand, Dr. Samin. Thank you very much.
And Dr. Keeney will say exactly what to do. What do you want to do?
No,
Medical therapy.
I will leave that everything alone.
Okay.
No FFR, no more OCT, nothing. Leave the patient alone.
And call back.
They'll do fine.
Okay. All right. Thank you very much.
Yeah. Bye-bye.
Beautiful.
Thank you. Big hand for